To the extent that we live our lives in a manner that is consistent with the truth in our heart, we thrive.
Welcome to the Meyer Clinics podcast, and you just heard a quote from one of your hosts, Dr. Lisa Day. Join our licensed clinical professionals from various backgrounds as they discuss fascinating mental health topics with a wide range of guests. Meyer Clinics is a Christian counseling organization with multiple clinics nationwide dedicated to treating the whole person, emotionally, physically, and spiritually. Welcome to our listening family. We thank you for joining us. Dr. Lisa Day, thank you so much for coming on again to do our podcast.
Oh, I'm always so happy to be here.
And we have a good friend to the network and a wonderful human being who's traveling and travels a lot, speaking about the very topic that we're going to be discussing today, Dr. Dave Vigerust. Dave, thank you so much for coming on the show.
Well, thank you very much. Pleasure.
Absolutely. So Lisa, I am not gonna rain on your parade because I know you have been doing some research for this particular podcast.
Well, it's near and dear to me, right? So the combination of being a registered nurse, or actually psychiatric registered nurse, and a clinical psychologist, it is right in my area of passion, right? Always looking at, where we are with psychotropic meds and the effectiveness of it. So yeah, no, I really enjoy it. Really enjoyed getting stuff ready for it.
Awesome. Well, then you fire away with your questions.
Okay. So, one of the reasons that I wanted to look at this topic, as I was mentioning earlier, is that as a nurse and as a clinical psychologist, oftentimes, obviously, we're going to refer psychotropic medication or medication management. And, the problem of depression is so vast in our country right now. I believe it's 1 in 5 folks struggle with depression, 150 million people worldwide. And, there are several reasons why people are continuing to struggle. And when we look at treatment and we look at patient care, the ones that come to mind is lots of people aren't seeking treatment because of the stigma still attached to mental illness. Lots of people, I think over half of Americans, don't seek it in general. Others, it's a lack of appropriate services. But 2 of the 5 main reasons why people are still struggling with depression, according to what I've learned, Dr. Vigerust, is they're discouraged or by failed medication trials or poor medication adherence because of the numerous side effects. So I'm super excited. As a psychiatric nurse, the numbers for medication management are pretty discouraging. I think that it's somewhere between 30 and 40% of folks who seek treatment for depression anyway, they respond on the first trial. But then there's another 30 to 40% who only get partial help. And then there's the remaining 30 to 40% that don't get any help at all. And so I'm super excited, to see the role that genetic testing can take place. And interestingly enough, sadly enough, and I'll ask you some questions about this, I learned of it through a client. I didn't learn of it through any of my readings and I don't know if I just didn't stumble upon it, but it was one of my clients who was working with an ARNP who said, I just did a cheek swab to see what medication I would respond to. And so help me understand, what is the process of testing for responsiveness to medication?
The process is really fairly simple. It's a non-invasive test. So our company uses an oral rinse. So this is basically just a 5 ml normal saline solution that you can put into your mouth, swish around for 30 seconds, and then spit back out. What that allows us to do is to capture buccal cells from the oral cavity. There's enough there in that 5 ml solution to extract the DNA necessary to look at the genes that are involved in drug metabolism. And that's across a broad spectrum of different therapeutic classes. So cardiovascular drugs, diabetes drugs, depression, anxiety, just about any medication that you could consider for any kind of chronic condition, any of them will process through the liver. And these enzymes that we're examining are those that you find in the liver that allow you as a patient or a recipient of the medication to convert it to an active drug, to convert it into a metabolite that can engage into receptors and elicit the effect that you're trying to get. And what you said already is very true. Oftentimes patients will struggle with this idea that they've been on medication that hasn't worked, hasn't improved any of their symptomology, makes them feel worse. It gives them side effects or symptoms that oftentimes are worse than a reason for seeking treatment in the first place. And they get really discouraged. And they get discouraged also when the physician goes through a number of different drugs, not realizing that the patient may not adequately metabolize or process the drug. So if you have a protocol, for example, say the doctor says, I always start my patient with this, and then if that fails, then I follow with this, and then I follow with this. So they have a schema of sorts on what their steps are in treatment. If you don't know how the patient may or may not metabolize a therapeutic class of drugs, the likelihood is you start off on one drug that doesn't work, you move them to another drug that's in the same class, in the same pathway, that also is not going to work. And you move to a third one. So what you have is 1, 2, 3, 4, 5 months of therapeutic attempts that don't work. So patients get discouraged, physicians get discouraged because the patient's not responding.
Not only do I see them get discouraged, unfortunately, from a clinician's point of view, I see them interpret it as that their depression is so severe that nothing's going to help, that nothing's going to work. And that not only with the depressive populations, but, with the more complicated, the bipolar populations, that nothing's going to work. And I've seen people go through 5, 6, 7, 8 different medications and then just throw their hands up and say, I'm done.
Yeah, my condition is not treatable. Right? That
Right.
sort of idea or thought process. And that's not true. There may be some patients who there isn't a class of med that would work for them to the degree that we would like to see in terms of response. But there's probably a number of classes that if we knew what the patient's phenotype, genotype was, meaning how they would or would not respond to a given medication, you can start with the ones that are in that likely category and not even approach the ones that are in the category of very low success.
So I wonder, because this is a question that comes through my office often, and I wonder if you can differentiate the pharmacogenetic testing. Thank you very much. That was a tongue twister for a Friday morning. Pharmacogenetic testing. I wonder if you can differentiate that from genetic testing for the diagnostic risk factors for, say, depression, anxiety, schizophrenia, bipolar. Because what I find is that as clients are talking more about this, they seem to be using those words interchangeably. And from what I read, it looks like they're two distinct different entities.
They are. The process for testing is similar. So we're taking a swab of DNA or a sample of DNA, running it through. Where the difference comes is the assortment and category of genes that we're examining for the two different purposes. So, if you're looking for ApoE, for example, that may be a risk factor for Alzheimer's or neurodegeneration. That's different than a CYP2D6, which is a liver enzyme whose sole responsibility is not a risk, but a processing of a medication. So they're similar in concept when it comes to how the sample is collected, how it's processed, how it's interpreted, because that's all, genes are genes. It's just a difference in what does the gene actually do for that patient. Does it confer a risk, or does it confer an ability or inability to process a given medication? So the pharmacogenomics is just looking at the class of enzymes and proteins and genes that are related to how a drug may be metabolized, processed, excreted, the kinetics of it, whereas the risk factors are telling you, well, you have this particular variant, and that may confer an increased risk of, this percentage with these other factors in place. As we know, it's not just one thing, right?
Right, and so it sounds like in many cases it might be beneficial to do both, but that the PGX or the genetic testing for the metabolism is more specific to care, where the other one, the genetic testing for DNA, is more risk. So diagnostically, it sounds like.
diagnostically right. So, and we do a little bit of both. We do a blending of both. So we look at the genes that are responsible for drug metabolism, drug excretion, drug kinetics, and then we have a number of genes on there also that may speak to how, like MTHFR or COMT or DRD2, how is the pathway in your serotonin or dopamine pathway, how is that affected by alterations in these genes? And that may be a risk factor for depression or anxiety. It's not so much telling you whether or not the drug will work, but it's telling you that there's some differences in your DNA that may lead to an enhanced risk or a possibility of not having a pathway that's optimized. And
no, so
I
that's
usually
interesting.
try to shy away from normal versus abnormal, because I don't know that that's an accurate assessment. But there may be pathways that are more optimized than others. So maybe you're more able to benefit from the dopamine pathway or the GRIC pathway or the serotonin pathway, or conversely, that pathway may not be optimal, so you don't receive the benefit of some of these, like the SSRIs, for example. Can you metabolize it? Yes or no? Do you benefit from the drug itself? So let's say that you process it perfectly, but maybe something in that pathway is not optimized or optimal, so you don't receive the full benefit of the drug, even though you can metabolize it.
I have a question for you. I hear you talk about the pathways for dopamine and the pathways for serotonin, and I know that in my efforts to talk with clients, my formal training in psychology is as a neuropsychologist, and so I try to explain to them the interplay of serotonin and dopamine and norepinephrine and what have you. And I explain to them from a nursing perspective that currently we don't have a blood test that can show that your calcium is too high or your red blood cells are too low. And, my understanding, and please correct me if I'm wrong, it's been years since I've looked at this stuff, is that the only way that we can assess cortisol, serotonin, norepinephrine would be through the cerebral spinal fluid. Is that correct? And if not, I guess the bigger question I would have would be, in your testing, so you're saying that you're able to test the genetic pathways of those neurochemicals, which is awesome. But I'm wondering if in your current work, or if there's work going on down the road where we could actually look at the different serotonin types and their levels, and the dopamine and the norepinephrine. Is there any testing for that currently, or is there any research going on in that regard?
You can do some of that. So cortisol, for example, you can do salivary cortisol, and you can get an idea for what the levels are. You can do blood cortisol. You can pick up these. You can pick up these from time to time in different types of assays. The sensitivity may not always be what you need. So going to the source, going to the CSF, might give you your best measure of that. And obviously, people don't want to go into a lumbar puncture to get an assessment of that, right? So we'd like to be able to find ways of doing that are relatively non-invasive, like a salivary cortisol. So the work is being done to try to improve those assays. As it happens, many of those assays, they take a long time to get through, number one, testing, and number two, approval from the FDA to show that they are diagnostic, that they're beneficial, that, there's just so much effort that has to go to that proof to show that it's, beneficial to the patient by doing this testing, that you can get clinically actionable results out of it.
And so when you say that the test is helpful in looking at medications for depression, anxiety, I think you said bipolar disorder, and some of the other popular ones, PTSD, OCD, or schizophrenia, it would strike me that we're actually diagnosing backwards. So for instance, if in our genetic testing we found that you metabolized Paxil better than you did, say, Prozac, we might then diagnostically go backwards and think that you have more of an anxious depression. So it's not that, but I'm not hearing that we're actually doing a test for depression medications. We're looking at which medications are likely to be best respond, and then looking at the symptom profile, then would pick a medication accordingly.
You could probably do it both ways. It doesn't have to be kind of the reverse. I see what you're getting at, but if you have a diagnosis already of depression or anxiety or whatever the case is, and you've gone through a course of therapy that's not been beneficial, you could do some of this testing to find out, well, is there a reason why that wasn't beneficial? Is the therapeutic class just the wrong class? for you because you have a 2D6 deficit or you have a 2C19 deficit, and those are liver enzymes. So those enzymes in the liver are a family of enzymes called cytochromes. There's 60 some odd, in humans, and about a dozen of them or so are related to processing of medications, either converting to a prodrug or converting backwards.
At what point in the treatment, so from a clinician's point of view or from a client's point of view, at what point in treatment are you seeing these tests used? For instance, if someone's going for a medication evaluation, are you seeing psychiatrists or general practitioners giving this test off the bat, or are we seeing that after there's been several failed attempts? Is there any pattern, or is it still too new to see those patterns?
Well, as it happens, this sort of technology has been around for almost 60 years. It's not new in the sense that it's new science. It's old science. The newness part of it is the ability to be able to do it in high throughput. So rather than having to take 2, 3, 4 days to do one patient, you can do 100, 200 patients, 300 patients in a 6-hour period. And the way that it's used both ways. So sometimes it's used after a patient has already failed a given therapy. And sometimes it's used from the very, very beginning. So they make a brand new diagnosis and they say, well, here's your diagnosis. We're going to make sure that the meds that we prescribe to you from the very beginning are the right drugs for you personally. And we're going to do that by doing this DNA test. And this DNA test is non-invasive. It doesn't hurt. It doesn't affect your insurance. It doesn't affect all those things. So people worry about, well, what happens with these results? Am I going to be discriminated with these results? So it's done both ways. Sometimes it's after a diagnosis when patient has failed therapy, and sometimes it's from the very beginning. And it depends on the clinician on what their perspective is. Sometimes they're very, very proactive and say, let's just do this right from the beginning. And sometimes it's, well, let me try a couple things first. Based on my experience, you're likely to respond to this. No amount of experience can any doctor look at a patient and say, you will or won't respond to this. That's not something you can do.
Absolutely. I mean, I know that in the 25 years that I've been a psychiatric nurse as well as a clinical psychologist, and my passion is psychotropic medications. I'm kind of a science geek in that regard, but I know that I can see clinical profiles of someone who would be more likely to respond to a dopamine-based medication versus a serotonin. But it strikes me, when we go to the doctor, we have our blood work. We have our CBC, we have a complete blood work as a part of our routine medical evaluation. And it would seem that perhaps we'll be moving to a place where psychiatrists would be able to do this out of the gate. And certainly I know that there's third-party reimbursement challenges and who's going to pay for it and the effectiveness of the test. But what I'm seeing is that research is showing that it's pretty accurate with regard to at least acknowledging what you're most likely to respond to with the fewest side effects. Where do you feel like we are in that process of it being a routine lab analysis, if you will, when you were to go see a psychiatrist?
It should be a routine part of this, just like you illustrate with the the CBCs and the chemistries. The problem has been the reimbursement strategies, and this was something 4 or 5 years ago that was routinely covered by insurance. Insurance covered this. Just about every one of the carriers covered this, and there were some bad actors in the laboratory space that took advantage of that and started testing everybody. So whether you had a condition or not that could be informed by PGX or PGT, they started testing everybody. They started billing very large amounts for every one of those tests. So the insurance companies backed away and said, well, now I think we're going to consider this investigational. But as I mentioned before, this is 50 years of science behind this. It's not new. It's well documented. If you look on the back of any one of the product inserts for these medications, they tell you what pathway that drug processes through. So it's part of the normal complement of data that goes to the FDA to say this drug goes to the liver, it goes to this gene or this pathway, it exerts this influence, it stays in the blood this long. So all of that is well documented science. I think this should be a part of every routine workup for any kind of chronic condition, not just the ones we're talking about, but it should be for diabetes, it should be for heart disease, it should be for arthritis, because so many of the drugs that we take on a regular basis for all of these myriad of conditions process through the liver. That's its job, is to do this. So it should be a proactive piece of every patient workup, whether it's this group of patients we're talking about now or any other patient that has a chronic condition. And I think we'll get there. But
Well,
we
yes,
can't get there until the cost comes down, until all of the various stakeholders start to see the value there. The physicians have to understand this is not intended to second guess their judgment. It's intended to help them pick the best course of therapy for the patient. I've run into doctors who say, no, I don't need this. I'm a good enough diagnostician and clinician that I could do this on my own. I'm not trying to replace your skill. I'm trying to supplement with a piece of information that you can't see from any other kind of physical exam.
Hi, this is Dr. Paul Meyer of the Meyer Clinics. There's times in our lives when our situation may seem impossible to resolve. In fact, almost everyone who's depressed feels like there's no light at the end of the tunnel. But God promises that there is nothing that's too hard for Him. When you're discouraged, remember that God loves you, He knows you by name, and our Christian counselors of the Meyer Clinics will also come beside you, speaking the truth in love. We offer biblically based counseling.
The Meyer Clinics, a nonprofit counseling ministry of the Meyer Clinic Foundation. For more information, 1-888-7-CLINIC.
Well, and I see it from a clinical aspect where, the average person with bipolar disorder, it takes them 5 years to get into treatment and on average 10 years to find the right medication protocol to give them stability. And in those 5 to 10 years, bipolar is one of the major killers of anything that walks in my office by suicide. And so, if we look at clinically, that so many people, it's not normal for a client of mine to go through 4 or 5 medications. They get frustrated and they say, to heck with it, I'm just going to deal with this. And so they live a subpar life at best, or they become suicidal at worst. And, so in the big scheme of things, and you and I probably could get really passionate and talk about this a lot, is that we talk about the cost benefit analysis. It seems as though there's much greater cost in failed medication trials and much greater cost in failed therapy and much greater cost, obviously, in a life by not having that tool. So hopefully,
Right.
as we grow and this becomes more popular, the MDs will see it as the lab work that the GP uses to diagnose pneumonia, or a thyroid disorder, that it's just a part of our protocol. I have a question for you,
Right.
though, and it gets a little complicated, and this is just my science junkie brain, so forgive me if I'm going too far. But when I look at this, I get super excited. But how effective, or does the test allow for when you have comorbid disorders? So I call it the smorgasbord. So if we have someone who's presenting with symptoms that really are look like bipolar disorder with an ADHD and a social anxiety, does the test come in and test all of those medications? Meaning, can it look at atypical antipsychotics, the SSRIs, the dopamine? Can it look at all of those, or do you have to do one test per one medication? And then the second question is, does it give any indication of where you should start? So oftentimes we're going to start with the most disabling, if you will, symptoms and
Right.
target those first. But I'm wondering if the genetic testing, is it able to do a broad span, or do we do single classifications? And then does it give any indication of where you should start based on which is going to be the most responsive to the medication?
Right. So the answer to that is yes to both of those questions. So the panel that we run most frequently is a 50 gene panel. So it looks at receptors, it looks at the processing in the liver, it looks at lifestyle, it looks at comorbidities, it looks at anticholinergic burden, it looks at Beers criteria, it looks at 9 different categories of not risk factors, but not conditions either, but circumstances that impact whether or not the drug will be most effective. So drug to drug, drug to gene, drug to lifestyle, drug to food, drug to all of these things. So we're looking at as broad a snapshot as we possibly can get. It keeps it manageable from the standpoint of getting data to the doctor. If I give you 4,600 genes, that's too much for the doctor to do much with. It's an
Right.
overload of information. If I give you 40 and I say, look, these are really just around these conditions, it's going to tell you how these drugs for depression and diabetes and cardiovascular disease, because they have multiple chronic conditions, how do all of those interplay together? Not just how does the antidepressant or the anxiolytic going to work. So we're looking at as many genes as we can to offer as much insight across the whole, continuity of the patient, not just the condition that they're there in your office for, but as it happens in a patient who has, depression or anxiety, they're seeing a psychiatrist or a clinician. That clinician actually ends up being the medication manager, because they're trying to balance what they're prescribing for this given condition with everything else the patient may or may not have. So
that's brilliant.
You turn out to be the med manager, and many of the psychiatrists that I've gone and worked with turn out to have that very function, because they say, my patient has heart disease, my patient has this, she has this, she has this, and she has this, and now I want to start her on an SSRI. Can I do that without causing some contraindication somewhere along the way with something else that she's got going? So the other advantage to that particular type of practice is that your type of practice has the time, and you spend time with your patient, right? I imagine it's probably never going to happen where you spend 7 minutes with a patient like you would if you're an internal medicine, right? But if you're an internist, if you're a general practitioner, if you're some of these other medical specialties, your time with the patient is very short, which means that you don't have time to go through a report that has 20 or 30 genes and all of the different possibilities that your choice of medication has in terms of impact with their other conditions or other comorbidities. So yours is the ideal kind of practice, because you spend time with a patient, you talk to them, you ask them what's going on with them, you find out what conditions they're being treated for. Even if you're not the principal person responsible for that cardiovascular drug, you still have to make sure that what you prescribe fits with their regimen that they're currently taking. So the answer.
So that being said, that I'm sorry.
Go ahead.
So that being said, that you can test, 40, 50, all kinds of medications, thyroid, heart, psychotropic medications. I know in the field of genetic testing, they speak of the concepts accurate versus precise. And my question is, and so it can be accurate that you metabolize to an SSRI versus an SRNI or something like that. But are you actually able to say, no, this client is going to do far better on Prozac than they are on Effexor? Is it that precise?
You can get close to that level. So, and I've argued this distinction too between accurate versus precise. Now, to me, accurate is somewhere in the ballpark, right? We're kind of where we need to be. And a patient, with a little bit of titration or dose adjustment or scheduling or something, can probably get it close to where it needs to be. I'd rather it be, I want to get you to as close to perfect, to as close to the target as we possibly can. And by doing that, by doing this kind of testing, you can get pretty close. Certainly a lot better than we've ever been able to do in the past. So not just, you'll respond to this class of drugs, but you'll respond to this particular drug within that class at this dosage, at this schedule, right?
That is fantastic.
Because then we can, and it goes beyond just the genetics, right? We also have to find out, well, how do you absorb? Do you have normal gut absorption? Do you have any epigenetics? Do you have any of these other things? So the genetics is a piece. So, I'm not one of those people who says, well, the genetics is the end all be all. It is the panacea. It's not. It's a piece. It's a piece in context with everything else that this patient's got going on for every other condition that they're being treated for. But it allows us to get to a place where we are being precise with the choice of therapy.
Well, it's very exciting
because the right drug.
You can have someone who presents to therapy with an incredibly anxious depression. So they look like they're pretty agitated. And boy, those people, when they come in, they're so uncomfortable. And, you can have before you, okay, do we do a Zoloft? Do we do a Paxil? Do we do a Prozac? Sometimes people flatline on Zoloft. They don't like how it affects their sex life. Some people with Prozac, they can become increasingly more at a greater risk to self. And so when you have someone who's in such distress with an anxious depression, boy, I would think that if we can look at a panel that we get back in 2 or 3 days, that could save us, 2 to 3 months with someone in that much distress, it would be nothing but an asset, in the treatment. It's very exciting, very exciting. What is
And
the average? So if it's not typically covered, or if it's not normal protocol in lab work, if you will, for psychiatrists or general practitioners, what is, or are you able to speak to a typical out-of-pocket cost to an individual client who would go to their general practitioner, psychiatrist, or naturopath and say, hey, listen, I'd really like to do this saliva test because I don't want to waste 2 months on finding the right med. Are you able to speak to an average cost to the consumer?
the average cost across the industry is probably a couple $100.
Okay.
So, and that depends on the depth of the test. So there are some tests out there for this particular class of patients that may only have 9 genes on it and may only look at 50 or so drugs. Then on the other end of the spectrum, you have some like our company who uses nearly 50 genes, and we cover every single drug that's in the Orange Book. So that means that the 1,500 drugs that are within prescribing ability within the United States under the FDA, all of those drugs have some impact, right? Not all of them are informed by genetic testing, but drug to drug and drug to gene and drug to lifestyle and drug to confusion and drug to all those other things. So you might have as inexpensive as $150 all the way up to maybe $400 or $500, depending on the depth of what they test and the number of drugs and the number of confounders that may be involved. So our particular test looks at 9 risk factors. So we look at pregnancy and lactation. We look at age, so Beers criteria. We look at anticholinergic burden. We look at drug to drug, drug to gene. We look at lifestyle. So what happens oftentimes is some things that you have as a lifestyle choice, your foods, alcohol, marijuana, whatever the case is, can impact the function of the liver enzymes and the receptors. So you take something like grapefruit juice, for example, in the morning. Grapefruit juice is a good example of an inhibitor. You drink that grapefruit juice in the morning, you think it's good for you, but it actually turns off one of the genes in your liver that helps to process the medication. So that means that your drug is not being processed right? Correct? If it's not being processed right, maybe you're being overdosed or underdosed. So you need to know all of those extra little pieces. It's not so much just the genetic, but companies can have a very simple, straightforward, you are able to take this drug or you're not able, or they can have something more elaborate where we're taking into account as many of your life factors, comorbid conditions, and we're putting together a report for you in that way. So cost can be probably on average a few $100 across the spectrum.
And so that was my next question. Here I sit on the edge of my seat is that, and I think you answered it for me, is can the metabolism of a certain medication change according to lifestyle? Meaning I think of, real popular right now in our society is this keto diet, right? That does the ketogenesis. And, my notion is that would affect your ability to metabolize meds differently than if you were not on a keto diet, meaning, so it's not as though someone can take this test and those would be consistent results a year later. It sounds like there can be many influences based on lifestyle. Is that accurate?
That's true. Right. Okay, so smoking can impact it. Leafy greens can impact it. Grapefruit juice. There's all kinds of things that could potentially impact the normal functioning of the liver or the gut or the kidneys, right? So drugs are going to process through one of those 3 routes. Most of them go through the liver because that's our filtration system, right? But some of them get dumped directly into the gut. They never go to the liver, and some of them are cleared via the kidneys. So if you have poor kidney function, that may impact whether the drug is at the right therapeutic dose. If you have poor absorption, that may impact whether, so knowing that you have a gastrointestinal issue and you're going to take this particular medication would be important in consideration of the dosing and the scheduling of the drug. And then whether you can process the drug would be the genetic component of it. Are your liver enzymes appropriate for that? Yes or no? Well, they are. Okay. Do you have any other conditions that may impact how I choose to dose you? Well, you have a GI problem, and that means that you have poor absorption. Okay, so then I might have to give you a drug that either has a longer last or sustained release, or maybe give it to you more frequently than I would give it another patient. All of that's consideration in this, right? So that's why I say that genetics is not a panacea. It's a piece. important piece, but it's a piece.
Yeah. And I like it, certainly, from a clinician's point of view, where we look at the whole person, and oftentimes clinicians, at least psychologists, are not the prescriber because they don't have the MD. But I like that fact that you can look at lifestyle, because many lay people don't know that grapefruit juice is going to interfere with your absorption of your morning meds, and how many people have fresh grapefruit juice in the morning. Right. And so simply to be able to make a modest modification in your intake versus your medication for a lot of folks is going to be encouraging as well. So it sounds like it's got more than just what med, but how can I, do I need to take this on an empty stomach, or when I'm taking it with such and so, or if the alcohol consumption is too high, you're not getting any benefit from it. It sounds like there's a lot of, potential input from the genetic testing beyond just, are you going to respond to Prozac versus Effexor?
Right. And as it happens, I didn't mention this before, you were talking about compliance and adherence. Patients, there have been a number of studies that have shown that patients that get genetic testing tend to be more compliant and adherent to their medications because they feel like it's more tailored to them, right? So rather than say, I'm going to give you a drug that we give to 99% of the patients who come in here, or I'm going to give you a drug that I think is most appropriate for you personally, given your genetics and your conditions and your unique circumstance. When you do that, the patient says, oh, you're doing this for me. You're not just treating me like you're going to treat everybody else. You're doing this for me. And because this is more tailored towards me, I'm more likely to be adherent to the program.
Well, I think there's another factor involved in that as well, because oftentimes when I'm talking to folks about antidepressants, and granted, this has changed a lot in the last 2 decades, but there still remains a stigma that, oh, I'm just going to take a pill and it's going to make me happy. And I've had a lifelong thyroid disorder. I had Hashimoto's. And so I often will give the example that though I would like not to take levothyroxine or Cytomel, if I don't take it, my hair falls out, my fingernails stop growing, and I have no energy. And so I try to explain to them, that they're very similar in the neurochemical differences, and in this case, the metabolism. And so, while at adherence, they feel better about the individual, lab tests, I think also it has great potential that it's not that I'm just lazy or weak, that there really is a neurochemical involvement in my body that is interfaced with metabolism, and I need this medication in order to function properly, which hopefully in the long run would help, continue to decrease the stigma associated with getting mental health services and going on psychotropic medication. So many positive implications for your testing. My one last question would be, who are we seeing this test most commonly given by? Are we seeing psychiatrists suggested? Are we seeing GPs? Are we seeing naturopaths? Or are we seeing clients drive that? Or is there not a single one that's ahead of the game? Are people using it across the board, or are we seeing it more in one area than another?
It's being used fairly uniformly across the board. So psychiatrists are using it, general practitioners are using it, internal medicine uses it. It's found across most of the specialties. My only caution, when you consider doing a test, is the groups that are offering this as a direct-to-consumer without clinician input. So there are a number of companies that have come out that are offering these things as direct-to-consumers. You can go online and you can sign up for your own test, and you get a report back, or you get data back that you can send to a naturopath or somebody to get a report back. If you look at those tests, they all very clearly say that this is for informational and entertainment purposes, and that if you find something of potential clinical significance, that you should get it backed up by a clinical test. So
yeah, no,
the caution that I'm making is, regardless of who you go to a laboratory that is regulated by CAP and by CLIA, that has clinically validated testing that's actionable, informative, that does what you're hoping it to do, right? So just because you can go and get it from a direct-to-consumer source doesn't necessarily mean that it has the same high level of quality and stringency that you would get from a laboratory, regulated clinical laboratory. So,
well, and then we don't want people going on the dark web or going to the Canadian pharmaceutical sites and ordering Prozac because that's what indicated on their lab result they respond well to. There's a lot of risk in that.
Right. So, the caveat, I think there's tremendous power in this kind of testing, but it needs to be done, with a high degree of stringency, have to have the controls in place. regardless of who you use, make sure that, they're a solid, reputable organization that's doing it, that the results are going to your clinician, and you don't make the decision unilaterally on your own just because the report says you shouldn't be doing this. Your doctor needs to be part of it, whoever prescribed the medication. That's where I get nervous, is when patients see a report and they say, this says I shouldn't take Prozac. Well, that may or may not be the case, because you may not be fully aware of all of the different considerations your physician is using in choosing that drug. Sometimes that still is the best drug. We've seen that in cardiovascular patients. Plavix is a great example of a drug that has a very definite genetic partner. And patients who have a certain genotype in one of the liver enzymes will not process the drug. And that happens in the general population about 30% of the time. So, if you see that your doctor has given you a particular drug and the report says that's not a good drug for you, they may have already had that under consideration. And given the other drugs that are available on the market, that still may be the best one for you. So discontinuing the drug without, insight from your physician or your clinician is discouraged.
Sounds good.
Fantastic. Well, thank you, Dr. Dave Vigerust with MyGenetx. I want to make sure that everyone has the website that they can go to. It's www.mygenetx.com. Thank you, Dave, for coming on and joining us.
Thank you. It was a pleasure.
Thank you. Thank you so much.
Absolutely. And Lisa, we will catch our listeners on our next MyGenetx podcast. We hope you enjoyed this podcast. Tune in next time for another engaging discussion on relevant mental health topics. If you have any questions about MyGenetx, please visit our website at myerclinics.com. That's MEIER clinics.com, or call us at 888-7-CLINIC. Don't forget to leave us a review on iTunes, Stitcher, or any of your favorite podcast apps. And please note that we are a member of and produced by Mental Health News Radio Network, MHNRnetwork.com.